My name is Anthony Porcelli. I go by Tony. I am an assistant dean in Hofstra University's School of Health Professions and Human Services. And it is my absolute pleasure to welcome you to this evening's event, the keynote address on health equity by Dr. Andrea Ault-Brutus at Hofstra University's 2021 National Public Health Week virtual event series. Tonight, it is my pleasure to begin by introducing the dean of our school, Dr. Holly Syrup, who will be offering opening remarks. Dean Syrup has been a fixture of leadership on Hofstra's campus for over 35 years and has had a number of roles in leadership, including serving as the executive dean of students, the vice president for campus life, prior to joining Hofstra's faculty. As a faculty member, Dean Syrup joined in 2006 at a dual appointment within the Departments of Counseling and Mental Health Professions and Educational Leadership. In 2015, Dean Syrup achieved the rank of full professor and became the vice dean of the School of Health Professions and Human Services, shortly thereafter rising to the role of being the dean of the School of Health Professions and Human Services, which is one of the newest schools on campus, but also one of the most rapidly growing schools on campus. Under Dr. Syrup's tenure, we have experienced a large growth in enrollment and expansion of academic programs at the graduate level. Dean Syrup's accolades also include having been named being named one of the top 50 women in business from Long Island Business News in 2019. Without further delay, it's my absolute pleasure to welcome Dean Syrup to offer opening remarks.
Good evening, and thank you all for joining us for the keynote address as we begin our celebration of National Public Health Week 2021. Our keynote this evening is on the topic of health equity and is being facilitated by Dr. Andrea Ault-Brutus, who is the Director of Health Equity for Nassau County's Department of Health. We'll learn much more about Dr. Ault-Brutus momentarily when she will be introduced by our second-year MPH student and president of Hofstra Society of Public Health Advocates Graduate Student Organization, Shweta Tenjori. The students in Hofstra School of Health Professions and Human Services, along with the students studying healthcare disciplines across the United States who are joining us online this evening, are the healthcare leaders of tomorrow. They will need to stay steadfast and become strong advocates for change. Unfortunately, inequity in health is not a new concept, and it will not go away unless there is a conscious, intentional effort to address these issues. To gain an understanding, we must examine the roots of health inequity, its connections with public health, and the present-day circumstances that bring to light the need, now more than ever, to carry on the efforts to improve health equity across the lifespan. Together, we can make a difference, and what we do today can impact all of our tomorrows. As we prepare to welcome Dr. Ault-Brutus to provide our keynote address this evening, it is my pleasure to ask Shweta Tenjori to provide formal introduction. Thank you.
Hi, everyone. My name is Shweta Tenjori, and I'm a second-year graduate student as part of the Master of Public Health program at Hofstra University. And I'm the president of SOFA, Society of Public Health Advocates. And we aim to engage in health promotion, education, and advocacy, both at Hofstra and in local communities. So just a little quick announcement that I wanted to make before introducing our keynote speaker was that for National Public Health Week, SOFA has decided to create a virtual event to go along with the theme of health equity. And we decided to create a poll in which people could respond to the question of what health equity means to them in 2 or 3 words. And basically the goal is to create this visual of what the Hofstra community thinks of health equity, and just to, I guess, emphasize the importance of health equity as a priority in the field of public health. So I'm going to include the information, the links to be able to respond to the poll, as well as my email, just in case anybody had any questions. With regards to today's event, it is an honor to introduce tonight's keynote speaker, Dr. Andrea Ault-Brutus. And I just wanted to say a few words about her before we introduce her. And so she's had about 20 years of experience improving health outcomes and access to quality healthcare for vulnerable and underserved populations. And before working at the Nassau County Department of Health, she was a senior director at the Mental Health Innovation Lab in the New York City Department of Health. And prior to that, she was working at research with health disparities at Harvard University. And her expertise includes community engagement, approaches to improving health solutions, improving quality of interventions in clinical and community settings, and analysis of qualitative and quantitative data. So we are so grateful to have her here today as a keynote speaker during Hofstra's National Public Health Week, just because our theme is health equity and just how important it is. And so we're so grateful for her time, and we're eager to learn about health equity. And so thank you so much.
Thank you so much, Swetha, for those kind words and for the introduction. And thank you so much to Anthony Porcelli and to the entire Hofstra MPH program community for inviting me to be a part of your National Public Health Week. It's an honor for me to be here, so thank you once again. I'm gonna see if I could share my screen. Tony, am I able to?
Yes, you have the ability to.
Okay, great, thank you.
And if I could, for everybody, if you have questions for Dr. Ault-Brutus at any point, please write them into the chat. We will be addressing them at the end of her presentation. Thank you.
Okay, hold on. Trying to get to, let's see, move this out the way. Okay, great, there we go. Okay. Can everybody see that okay? Okay, great. All right, so once again, my name is Dr. Andrea Ault-Brutus, and today I'm going to talk about the intersection between health equity and public health. And the title of my presentation is The Need to Finally Improve Health Outcomes for All. So before I begin, I want to talk a little bit more about my office within the Nassau County Department of Health. So I am the Director of Health Equity at the Nassau County Department of Health. And the mission of my office is to work towards eliminating health inequities within Nassau County by providing leadership and guidance on best practices to reduce inequities in vulnerable and underserved communities of Nassau County. So how do I do this? And how does our office do this? Well, we partner with community stakeholders to conduct health promotion programs. So a lot of the partnering I do is with other offices and departments within Nassau County, such as the Office of Minority Affairs, Office of Health Equity, Office of Asian Affairs, and our other departments of social services and human services, and also with churches and community groups, healthcare providers. All of these stakeholders are needed to ensure that we are reaching as many community members as possible, especially in those underserved communities. We also provide guidance on best practices that address health and healthcare disparities. We also disseminate data and information pertaining to health equity, similar to what I'm doing this evening with disseminating information about health equity. We do several webinars, and now in this COVID pandemic, a lot of our work is virtual. So we have webinars pretty much every month, about 3 or 4 webinars a month, discussing various health issues. Obviously, we talk a lot about COVID-19. We have a webinar series right now on the vaccine, but we also talk about other health issues such as cancer, heart disease. Next week, we're going to do a webinar on maternal mortality. So we're trying to provide as much information as possible to empower people with this information so that they can make better health decisions for themselves. And a key aspect of the work that we've been focusing on for the past year has been on COVID-19. I started with the health department in November of 2019. And as you know, it's February, March of last year when we were hit with COVID-19. And all the grand plans I had to address various health equity issues kind of had to take a back burner, go on to the back burner, because we had to really focus on COVID-19. And we had to first think about, okay, we need to make sure we get testing in the underserved communities. And then we were able to do that partnering with our federally qualified health centers, which were conveniently and thankfully located in a lot of those communities that were hardest hit by COVID-19 in Nassau County. And then towards the end of last year, starting to pivot and think about, okay, now we have to get people vaccinated. And as many of you know, there's great hesitancy in communities of color in regards to the vaccine. So really working with our community partners and thinking about, okay, how can we provide information to our communities that are concerned about the vaccine, but also how can we ensure equitable distribution of the vaccine to those living in those hardest hit communities. So once again, partnering with our hospital systems, our churches, our community groups to work hand in hand to make sure that we get those vaccines in people's arms who want to get the vaccine, and trying to, again, educate others on what was the vaccine, how was it made, why was it made so quickly, addressing people's concerns about the vaccine, which we'll talk about in this keynote, as to why people had genuine concerns about getting the vaccine. And before I go any further, I want to talk about, well, what is health equity? I like to use this particular definition of health equity. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. Achieving this requires removing obstacles to health, such as poverty and discrimination and their consequences, which include powerlessness and lack of access to good jobs with fair pay, quality education, housing, and healthcare, and safe environments. So this is a very all-encompassing definition of health equity. And the goal is to really ensure that we are putting all policies, all procedures, all services, anything we can in place to ensure that no one is left out in enjoying good health outcomes. So I have a picture here that is often used when discussing health equity. And as you can see in the first panel, there's three individuals who would like to enjoy the baseball game. But as you can see, they all were given the same stools. And unfortunately, even though they all were given the same exact stools, not everyone can really, benefit from that stool in order to enjoy the game. So the idea of equity is to ensure that for those who are disadvantaged or are living in communities of color where it's under-resourced, we want to make sure we provide those tools, those services, so that they too can enjoy the game. But really what we want to move towards is liberation. We want to remove all of those barriers to people from getting the healthy outcomes that we all want everyone to have. A lot of the reasons why we have the health outcomes we have is because of a concept called social determinants of health. And I'm sure many of those, I'm sure everyone in the public health program at Hofstra knows about social determinants of health. But for those in the audience who do not have a public health background, what we mean by social determinants of health are where people are born, learn, live, work, and play, and age affect a wide range of health outcomes, functioning, and quality of life, and those risks associated with that. So here are some examples, some categories that make up that framework of what we call social determinants of health. So if you look at the right hand, you see health care access and quality. And this is the link between health and access to health services, including health insurance. In the next panel, you see neighborhood and built environment. And here is where you see the link between health and where one lives, including access to transportation, crime, availability of healthy food, and quality housing contributes to your health outcomes. In the next panel, we see social and community context. Here we see the link between health and the social context of the community in which you live, such as experiences with discrimination and racism, which I'll go more into in this talk. Also here you see where social networks play a role in how it improves, how it intersects with one's health outcomes. In the next panel, we see economic stability. And here you see the link between health and income, cost of living, employment, wealth, housing stability, and food security. And in the last panel, we have education access and quality, where here you see the link between health and education and the quality of that education. So all of these factors are determinants of your health outcomes. And these are all factors that we in public health need to address to ensure equitable health outcomes for everyone living in our society. But a major component of these issues does focus on racism being a public health crisis, and racism is a public health crisis. In the last year, we've been really focused on COVID, obviously, as our public health crisis, but in the backdrop for centuries has been the original sin of racism in this country. So what is racism? And what I mean by racism, I'm really thinking about institutional racism. And there's several definitions for institutional racism. I'm going to share two in tonight's talk. So one definition that I really like a lot is by Dr. Kamara Jones, who is a prominent figure in the field of public health. And she defines institutional racism as differential access to the goods, services, and opportunities of society by race. Institutionalized racism is normative, sometimes legalized, and often manifests as inherited disadvantage. It is structural, having been codified in our institutions of custom, practice, and law. So that's just one definition, but I want to share another definition that recently came out by my former boss, Dr. Bassett, and colleagues. This article was written in the New England Journal of Medicine a couple of weeks ago, and they define racism as not simply the result of private prejudices held by individuals. It is also produced and reproduced by laws, rules, and practices, sanctioned and even implemented by various levels of government, and embedded in the economic system, as well as in cultural and societal norms. So here, Dr. Bassett and colleagues, they see racism as something that needs to be confronted, not only by addressing individual attitudes, but also transforming and dismantling policies and institutions that allow racism to exist in the first place. So there are so many examples of racism in the healthcare system. And a lot of people talk about the infamous Tuskegee study. But this is one of many examples of where we see racism manifesting itself in the healthcare system in the United States. But for those who heard of Tuskegee, but don't really know what happened in Tuskegee, I'll share a little bit more about what happened in that study. So the Tuskegee study occurred between 1932 and 1972, so over a 40-year period, where the United States Public Health Services withheld adequate treatment from hundreds of poor Black men who had syphilis. And so when it came out that this is what was happening, it immediately was shut down. It took 40 years to be shut down and was shut down. And from this study, many changes have occurred in research in the United States. So from this study, we have now the Institutional Review Board to make sure that something like this never happens again. And also data review and monitoring boards to make sure that when we do collect data from various communities, that we're doing it in an ethical manner. But it's also other examples of these types of mistreatments in the healthcare system in the United States. Dating back to slavery times, here's an example of Dr. James Marion Sims, who's considered the father of modern gynecology. And he forced enslaved women into experiments without anesthesia that helped to perfect techniques and tools used in gynecology today. We have examples with even current time, Henrietta Lacks, where in the 1960s, I believe, she was a patient of a doctor who was affiliated with Johns Hopkins, and he, without her knowledge, took her cells, and it's used now in medical research to this day. And her family, and Henrietta Lacks and her family, never knew that these cells were taken from her. And now that this has been discovered, now they're finally getting their payment for utilizing her cells. But even before she died, she never knew that these cells were taken from her. So these are just a few examples of the mistreatment and the horror that has occurred for people of color living in the United States. And it forms the basis for why people are hesitant today for taking the COVID vaccine. And these are some of the bigger examples, but there are so many other examples of mistreatment in the healthcare system. In 1984, the Secretary of Health and Human Services, Margaret Heckler, commissioned a report to finally take a comprehensive look at how Black and other minorities were experiencing health and healthcare in the United States. And they found that, unfortunately, Black minorities, other minorities living in the United States, did have poor health outcomes, less access to healthcare, and we had to really think about how can we improve these services and access to care to ensure equitable health outcomes for everyone. And if you fast forward to 2003, the Institute of Medicine, which is now known as the National Academy of Medicine, convened a panel of experts to document evidence of racial and ethnic disparities in the quality of healthcare and access to care delivered in the United States. And they reviewed more than 100 studies and concluded that bias, prejudice, and stereotyping contributed to widespread differences in healthcare by race and ethnicity. And if you fast forward to 2018, the National Healthcare Quality and Disparities Report documented that people of color continue to receive poor quality of care compared to white patients. And even in 2016, another study conducted with medical students and residents found that half of medical students and residents held unfounded beliefs that there were biological differences between Black people and white people, and that these differences were associated with the false belief that Black patients' pain were less severe than white patients' pain, which in turn was associated with less appropriate treatment decisions for Black patients. And if you fast forward to even last year, while we were in the COVID pandemic, I'm sure many of you probably heard about the story of Dr. Susan Moore, a physician in Indiana who had COVID-19 and was hospitalized, but felt that she was getting poor treatment from the doctors in the hospital where she was. And from her hospital bed, went on social media to let the whole world know that she was receiving poor treatment from the doctors. And unfortunately, that led to her succumbing to COVID-19 2 weeks after she made those videos. So we see here many issues that contribute to people having a lot of mistrust and distrust of the healthcare system in the United States. Actually, I'll give you even another examples of where you see the rates of healthcare by race and ethnicity, and you see how it disproportionately affects communities of color. So for example, we have here rates of new cancer by race ethnicity, and you see here that for rates of all types of cancer by race and ethnicity, Blacks and whites are pretty much similar to each other in terms of getting new cancers in the United States. But if you look at death rates by race and ethnicity, Blacks are more likely to die from any type of cancer when compared to white individuals. We see here also with breast cancer, Blacks are a little less likely to get breast cancer compared to white individuals living in the United States. But when you look at the death rates of breast cancer, Blacks are significantly more likely to die from breast cancer compared to whites who get breast cancer in the United States. Even looking at colon cancer and rectum cancer, where Blacks are more likely to get colorectal cancer and also more likely to die from colorectal cancer. And we don't see this just not in cancer, we see this in HIV/AIDS, we see this across chronic conditions, diabetes, asthma. Another big issue, this was a really big issue that was really gaining steam before COVID, was the issue of maternal mortality. We heard countless stories, including Serena Williams' own story about not receiving the care she thought she needed to receive when she gave birth to her daughter. Across the country, maternal mortality is a huge issue. And the United States is the only high income country where maternal mortality is on the rise. Black and Native American women are 2 to 3 times more likely to die from a pregnancy or childbirth related complication than white women. These disparities persist across varying levels of education and income, as in the case of Serena Williams with income. Systematic racism is a risk factor for poor maternal health outcomes. Also, there's an issue of infant mortality as well, whereas Black babies are 2.3 times more likely to die within the first year being born compared to white babies. So we see tons of evidence that these health inequities exist. And we've really, as a public health system, need to do more about these particular issues. And last but not least, COVID. COVID really shone a glaring light on the health inequities in the United States. Unfortunately, when it comes to COVID, it impacts our communities of color disproportionately. As you see here in the data provided by the CDC, white individuals are actually Black, Hispanic, and American Indian, Alaska Native, and non-Hispanic persons are more likely to not only get COVID, they're also more likely to be hospitalized with COVID, and are also more likely to die if they were to get COVID. So we see here how the decades and decades and decades of health inequities has contributed to our communities of color being the most vulnerable to COVID-19. So we see here that we have 2 pandemics coinciding with each other, intersecting with each other, the issue of COVID-19 and the issue of systematic racism, institutionalized racism in this country. Just a little more closely at Nassau County, because unfortunately Nassau County is not immune to what happens in the country. Even though Nassau County is the 13th wealthiest county in the United States, and even though Nassau County is ranked #1 in New York State for health outcomes, health factors, and health behaviors, this is not seen, this is not experienced by all of those living in Nassau County. Before I go into some health outcomes, we see here that in Nassau County, of course, the majority of residents in Nassau County are white, but we have roughly 12% of our county made up of Black individuals, 9.9% made up of Asian Pacific Islanders, and 16.8% made up of Hispanics. This is from, this data is from 2014 to 2016. But if we look at some of the health indicators, we see disparities exist within our county. So for example, we see here for infant mortality, Black babies are more likely to die within the first year being born compared to white babies. So if you see here, the infant mortality rate per 1,000 live births is 8.7 for Blacks, compared to 2.5 for whites, 2.4 for Asian Pacific Islanders, and 2.5 for Hispanics. And infant mortality rate is a measure of human deaths in a group younger than 1 year of age, and it's an important indicator of the overall physical health of a community. We see it in other health outcomes as well in Nassau County, where Black individuals are more likely, and Hispanic individuals are more likely to have asthma and more likely to be hospitalized with asthma. We see it in the area of heart disease and stroke, where Black individuals are more likely to die from heart disease and be hospitalized with heart disease. We see it in diabetes, where Black individuals are more likely to have diabetes, to die from diabetes. And we see it with our cancer rates, also where Black individuals are more likely to have late-stage breast cancer, and also more likely to have cervical cancer as well. So we see here, unfortunately, Nassau County is not immune to these health inequities. And we also see with our COVID data as well. This data is from April 3rd, as recent as April 3rd. And we see here that even though the Black population in Nassau County is roughly 12%, we make up 17% of the deaths related to COVID. So we see here that there's a real need to address health inequities in the county, even though we are fortunate to have great wealth, and also at an aggregate level, we are fortunate to have great health outcomes. These health outcomes are not shared by everybody living in Nassau County, and we really need to do more about that. So I'll talk more about public health and health equity and how they intersect with each other. So first of all, as many of you know, I'm sure a lot of you know a definition of public health, but for those who are new to this term, who are not from the Hofstra community, public health is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. Now, public health is ideally something that is experienced by all individuals, but oftentimes that's not the case. And unfortunately, as you see with the health inequity data that I showed previously, we need to do more to ensure we have policy structures in place to ensure that we have public health goods for everyone in the community so they can all experience better health outcomes. One of the things that really has hindered public health from doing all that it can to ensure healthy outcomes for all individuals is that there has been systematic disinvestment into public health. As you see here from some headlines that have come out within the last couple of years, in the midst of COVID, we see here that there's been historical defunding of public health, which has left the infrastructure of the public health system really vulnerable to COVID-19, which is why we had what we had happen last year, where we were, really late with getting testing to everybody. We were scrambling to understand what was happening. Why were we even being, impacted by COVID-19, and also late to understanding how it was really affecting our communities of color. But one of the reasons why we had these issues was because we were not funding public health adequately. I'm just going to show a couple of graphs to really illustrate this. As you see here, most state public health agency staffing and spending dropped over the last 10 years. You look at staffing from 2010 to 2019. So since 2010, spending for state public health departments has dropped by 16% per capita, and spending for local health departments has fallen by 18%, according to a Kaiser Family Health Foundation and Associated Press study. At least 38,000 state and local public health jobs have disappeared since the 2008 recession. And as we see here, most states spend less than $100 per person on public health. So we see overall that over the last 15 years since the Great Recession, the US public health system has lost 40% of its inflated and adjusted funding for staff, training, equipment, and supplies. And that from 2005 to 2020, there has been a 25% drop from $900 million invested into public health to just $665 million. So we see that this systematic defunding over these years have really left our public health infrastructure extremely vulnerable. So what can we do about this? What can we do? So right now, the good news is that with the new administration under President Biden, there has been more of an investment into public health. Recently, his administration passed the American Rescue Plan, which has put $100 billion to address urgent public health needs and enhance future efforts. Of this $100 billion, $7.6 billion has been earmarked for hiring public health workers, which is great. But critics do say that this is not enough, and that more sustained funding will be needed over the next decade and beyond to really address the problems that were created by decades of underfunding. So one of the issues that we have with health equity is that not only has there not been a concerted effort to address health equity, but there has been underfunding in the healthcare system, in the public healthcare system to begin with. So now that we are addressing the funding issue with this American Rescue Plan, what else can we do to ensure that health equity is a focus of the health departments? One thing that is currently underway right now is also looking at what does it mean to provide public health. So here is a diagram of what was called the 10 essential public health services. This was created in 1994 by major public health organizations and governmental agencies, which joined together to develop this public health functions steering committee, where they developed the 10 essential public health services as a means to communicate the key public health services needed to protect and promote public health. So you see here that at the center of this framework was research. And this was to say that with all that we do in public health, it will be guided by research and evidence-based practices. And there's several central services such as evaluating, monitoring health, informing, educating, and empowering the public, mobilizing community partnerships, enforcing laws, ensuring a competent workforce. So these were all seen in the early 1990s as essential components of public health. But what you see missing here is the idea of health equity. You see nothing in this framework to say that health equity is also a component of ensuring that we have public health for everyone in society. So there were some governmental leaders and public health leaders last year in the midst of COVID-19 who felt that, you know what, we need to do more to ensure that health equity is a part of what we're doing in public health. So they decided to revise these 10 essential public health services, and it came up with this new framework where equity is at the center of what we do in public health. So not only are we going to be working to ensure overall health for all in society, we're also simultaneously ensuring that equity is at the core of what we do in public health. And you see also there are essential services added now to ensure we are addressing health equity. For example, making sure we build a diverse and skilled workforce, making sure that we enable equitable access. And this components that were in the previous framework, for example, working with community partners, assessing and monitoring public population health. But all of these components really need to ensure that we are driving to not only improve health outcomes in general, but to really ensure that those who are most vulnerable, those who are underserved, are also benefiting from these public health goods. So this is just a framework. Community leaders, public health leaders, governmental leaders are now working with local health departments, state health departments, accrediting agencies, public health schools to ensure that this framework is now guiding the work that we do. But this is only a beginning because this is only a framework. So our very next steps are to work with our governmental agencies, to work with our healthcare systems, to work with our community leaders, to ensure that as we come out of this pandemic, we are really working together to ensure that equity is at the core of what we do. Thank you.
Thank you very much, Dr. Ault-Brutus. That was outstanding and an excellent presentation and keynote address. You're speaking, your entire discussion and presentation has just been simply outstanding. And I welcome, for those of us who are still in attendance, if you have questions for Dr. Ault-Brutus, to please put them into the chat and I'll be happy to relay them. As we are continuing to think about and formulate questions Dr. Ault-Brutus, I actually had one I wanted to ask you, if that's okay.
Yes, go ahead.
My question is, do you think a best practice or approach in terms of a response would come from the federal level, or would it be more so from the local level of government?
Well, I think with health inequities, you know, as we know in research, that there's multiple factors contributing to health inequity. So I do think that the solution has to be all-encompassing. Therefore, all levels of government, federal, state, and local, need to address these issues. Obviously, when you get mandates from the federal government, from the state government, it then makes the local governments do what they need to do. But at the same time, we could start local as well. For example, in our own health department in Nassau County, prior to me coming, they had all mandated positions in the health department. My position is not a mandated position. So they saw that, you know what, we have health inequities in our county. While it's not mandated for us to do anything about it, we do think it's important for us to do something about it, which is why my position was created. We actually had someone in the health department who was doing this work, Dr. Carolyn McCummings, who's now the commissioner of the Department of Human Services. She was doing this work, but she was still in a mandated position. She wasn't in a position that was labeled Director of Health Equity. She was in her mandated position doing the work that the mandate required, and additionally doing the work that to address health equity. And when she was promoted to commissioner, the health department decided, you know what, we still want someone to focus on this work. And that's when I was hired to focus solely on this topic. So locally we saw that there was an issue. But obviously more needs to be done. Just hiring a director of health equity, it doesn't stop there. We need to make sure that we actually, right now, I'm part of the Health Equity Task Force for Long Island. Now, this task force is one of 10 task forces from the state that came out of COVID-19. Our immediate mandate is to address COVID-19 in Long Island, but Nassau and Suffolk County. Northwell heads up our Health Equity Task Force. But one of the things that the CEO of Northwell stated in one of our meetings is that, you know what, once we get past COVID, and hopefully we get through it soon, we can't disband after that. We need to continue to work together to ensure that we are doing all that we can in Nassau County to address health equity. So to answer your question, I don't think it's just one level. We need to really attack this from as many levels as possible.
That was fantastic. Thank you for that very thorough response. And you're absolutely right. It can't just be coming from one particular area. I did get a question sent to me via direct message in the chat, which I'm going to read out loud. And for everyone in the audience, you are welcome to write your question into the general chat, or you can write it directly to me, and I'll be happy to relay it. But the question that I have here is, were there any lessons learned in terms of what to do and what not to do to promote health equity during the COVID-19 pandemic?
I think one of the lessons learned, and it was learned too late, obviously, is, we know from past issues in the country, SARS, the H1N1 flu, it was a pandemic. It wasn't a pandemic, but it was H1N1 issue we had a few years ago, that communities of color are hardest hit when we have these types of issues. Or even like Hurricane Katrina or any hurricanes we have in the country, we see that those living in communities of color are usually more affected by these types of natural disasters. So I do think that when COVID-19 hit us, I think we didn't think immediately that, we need to ensure that communities of color are protected against this. And I think, it was only when the data started coming out nationally and by the state and by local government that we saw, wow, the rates of COVID is much higher in communities of color compared to other communities. So I feel like we should have said from early on, more than likely this is going to hit our communities the hardest, those communities the hardest, and therefore let's act accordingly. I think when it came to the vaccine, I think we did have some forethought in mind that, you know what, communities of color are gonna probably be more hesitant to take the vaccine than others. And so while we were waiting for the vaccine, we were thinking about, okay, we need to ensure, you know, we get information out to communities of color. We need to ensure that we are working with community leaders, with faith-based organizations, from civic organizations, working hand in hand to ensure we're getting people in the door. We need to also understand how technology is a divide as well. Many people, you know, not just communities of color, but many people don't have access to technology. We have to ensure that technology is not a barrier to people getting the vaccines that they need. We need to ensure also cost is not an issue. And thankfully in Nassau County, we do provide free testing for COVID and also free vaccines. So I think, you know, we did a lot of good things, but there are things where we could have done better.
Thank you for that reflection and that fantastic response. The next question that I received asks, what needs to be done differently to reduce and ultimately eliminate maternal mortality in Black women?
Well, I think we first have to work with our hospital systems. I think there's been a lot of great research on maternal mortality. So we know that this issue exists. And I think when it comes to health equity, this research in general, many people decades ago questioned if these are even issues that exist. And we see from the Unequal Treatment Report, and we see from tons of research that these issues exist. I think that one of the things we need to do is implement programs in both hospitals, community levels, where we are working with mothers from communities of color, and equipping them with information to empower themselves, to demand from the providers what quality care that they believe that they should receive. One of the initiatives that's going on right now at a federal level that needs to be more widespread, well, it's at the CDC, but it needs to be more widespread, is called the Hear Her campaign. And it's an initiative that helps women of color have information, understand what kind of questions should you ask your healthcare provider? What should you be concerned about within the first year of giving birth? What you should be concerned about when it comes to your child to make sure they are well. And also training providers on how to address those concerns of women. I believe that these types of programs where is a focus on shared decision-making, ensuring that both patients have information and also providers have the training to work with patients to help further empower them and to come up with solutions and strategies to ensure that these mothers are having better health outcomes and also reducing their chances of dying and having complications after birth. So overall, I think we need to both address the providers by giving them more training and also empowering patients so that we could have, so they could together have better informed decisions, share decisions to improve their health outcomes.
Thank you, Dr. Ault-Brutus. Your responses have just been fantastic and very thorough. The next question that I'm seeing asks, and we have time for about one or two more, how do we convince more members of our community that we need an equity-centered approach to public health?
I think, the one sad thing about COVID-19 is that it really has shown everybody that, these health inequities exist. There are going to be a few people, however, who are never going to, change their minds on these issues. And, that's unfortunate, but thankfully, I think we can still work around those people. So we have to work with our governmental leaders. We have to work with our hospital systems. We have to work with our insurance companies. I think one group of people who tend to get, we need to hold their feet more to the fire are those insurance companies, because they actually are the ones that enable this poor quality of care to continue. If you think about it, you look at a hospital in a underserved community, a lot of times it's a safety net hospital, and you look at a hospital in a more well-to-do community, if you look at the patient population and you see who's insured, you see that in the more well-to-do community, they have private insurance where reimbursement rates are higher. Whereas you look at the safety net hospital, they have Medicaid, they have insurance program, they have insurance that doesn't pay at the same level, reimburse at the same level as those who have the private insurance. So I think we need to, first of all, address that inequity right there. Why is Medicaid reimbursing at a lower rate compared to a private insurer who's reimbursing at a higher rate? But that enables the safety net hospital to have lower providers who work for them, who have lower salaries, which therefore makes it not that competitive for them to get people who are, stellar in their field. It really is a vicious cycle. The good news about safety net hospitals is that, there are so many people who are still mission driven and still, go to those hospitals to provide the quality of care that is needed in those communities, but we need to do more to ensure Medicaid and other insurance companies that reimburse at a lower rate are, reimbursing at a higher rate. We also need to work with insurance companies so that they can incentivize hospitals to provide better quality of care. There is a movement to move from a fee-for-service model to a value-based model, where in that model, you are prioritizing better health outcomes for your patients. So you're not just paying for more services, but you're paying for better services. So I do think that there's a lot we could do in that area, where we are now incentivizing hospitals to do better for the community, not just get money just because you're giving out tons and tons of services, but you're actually delivering higher quality services.
That was, once again, fantastic response, Dr. Ault-Brutus. I think we have time for one more question, if that's okay with you.
Yes, go ahead.
Thank you. And to everybody in the audience still, I appreciate you for posing questions. If we do not get to a question that you have asked, Dr. Ault-Brutus, do you mind if I send them to you in an email to perhaps offer a response at a later time?
Yeah, that's fine.
Thank you so much. The last question for this evening states, what do you think needs to be done in order to earn the trust of the Black community in regard to the medical system?
I think we need to first acknowledge that their concerns are valid, number one. And I think number two, we need to work with, as a Black person, we need to work with the Black community. I think that a lot of the solutions to a lot of our problems actually may reside in our community. So I don't think that these solutions that we come up with to address health equity should come from the ivory tower. It shouldn't just come from people at the top, but we should really work with community members. We should work with trusted community leaders. We should work with our churches. We should work with civic organizations. We should work with everybody hand in hand to come up with solutions that would be best for everyone. I think that in my own research, actually, I feel like the best programs we put in place were the ones that were co-created, developed with community members working side by side with us. So I do think, number one, I know there's a hesitancy participating in research, but I think there needs to be more people of color participating in research and helping with developing research studies. There's this concept called community-based participatory research, which when I was a researcher, that's the kind of research I did do. And I think that it's a great approach in working side by side in an equitable fashion, where the researchers and the community members are thinking about, okay, what kind of studies can we conduct to ensure that we are researching an intervention that will be most beneficial to our community. So I think overall, we have to work hand in hand with the community in order to address these issues in health equity.
That was a fantastic response, Dr. Ault-Brutus. Thank you. This brings us right to the 8 o'clock hour. And I want to be respectful of your time and everyone's time who's joined us this evening. A very special thank you to all for being with us for the duration of this presentation, and an incredibly humble thanks to you, Dr. Ault-Brutus, for taking the time out of your evening to provide the 2021 virtual keynote address for Hofstra University's National Public Health Week celebration on the topic of health equity. Your presentation was outstanding. It was informative. It was inspiring, and your responses were spot on each time. Do you have any closing remarks that you would like to share before we sign off?
I just want to say thank you so much for inviting me to be a part of your National Public Health Week activities. It's great to see that even though we are in the midst of the pandemic, that you're still putting on these activities because they're so beneficial to our community across the board. So I want to say thank you for inviting me to be a part of this. I hope that it was informative for everyone who listened. And I look forward to continue to working with members of the Hofstra community on other initiatives together. So thank you.
Absolutely, our pleasure. Thank you all once more. It is our pleasure to have had you tonight. We hope that you can attend another one of our National Public Health Week events, all taking place virtually throughout the remainder of the week. You can see our events online, hofstra.edu/NPHW2021. Thank you once more, and I wish all a wonderful evening.